I want to tell you something that most surgeons do not do. 3 months ago, I became a patient. It was just me, a room, and an ultrasound screen showing my own carotid arteries. There were no operating lights, no team, just silence and a truth I could not ignore. I have spent over 30 years as a surgeon. I have performed than 2,000 open heart surgeries. I have held beating hearts in my hands more times than I can count. Yet there it was. Plaque. Not severe, not immediately dangerous. Present. It was sitting quietly inside my arteries like a warning that had been building for decades. Most doctors in my position would have done what we tell patients every day. Monitor it, take a statin, come back in 6 months. I did not follow that script. I decided to look deeper. What happened over the next 3 months changed the way I think about cardiovascular disease completely. Today I am going to walk you through what I did, why I did it, what the research suggests, and why this conversation almost never happens inside a normal cardiology appointment. Here is the first thing most people never realize. Arterial plaque does not appear suddenly. It does not begin the year your cholesterol report looks bad. It does not start the moment your doctor says your arteries are narrowing. It begins decades earlier, quietly, slowly, layer by layer. By the time most people reach their 60s, some degree of buildup is extremely common. That is not meant to scare you. That is simply how the biology works. So the real question is not, do I have plaque? The real questions are different. How much is there? How fast is it growing? How stable is it? And is there anything that can actually help move it in the direction? To understand that, you first have to understand what plaque really is. Most people imagine plaque as greasy cholesterol stuck inside a pipe. That picture is wrong. Your arteries are not plumbing pipes, and plaque is not just fat sitting on the wall. Think of the lining of your artery like the inside surface of a smooth garden hose. When that lining becomes damaged by blood pressure, smoking, high blood sugar, oxidative stress, or chronic inflammation, your body responds. It treats the damage like an injury, so it sends in a repair crew. That repair crew includes LDL cholesterol, cells, inflammatory molecules, calcium, and a protein called fibrin. Fibrin is especially important. It acts like scaffolding. It creates a framework. Then cholesterol, calcium, dead cells, and other debris become trapped inside that framework. Over time, this forms a plaque. So plaque is not soft cholesterol. It is a structured, hardened, organized buildup inside the artery wall. It has a skeleton, it has activity, it has oxidized cholesterol, and it has a fibrin framework helping hold it together. That detail matters enormously, because if plaque has then one component, then one single approach may not address the whole problem. LDL cholesterol becomes especially dangerous when it becomes oxidized. Oxidized LDL is one of the triggers that tells the immune system something is wrong. It fuels inflammation inside the artery wall. After the age of 60, the body's natural antioxidant defenses are usually not as strong as they were decades earlier. That means oxidation can become easier, inflammation can last longer, and plaque can become more active. So now you have three problems happening together: oxidized LDL triggering damage, inflammation keeping the process alive, and fibrin helping lock the plaque structure in place. Three different mechanisms, one result. If three different mechanisms are helping create the problem, then it makes sense that you may need more than one tool to address it. Now let me be clear. Statins are real medicine. They lower LDL cholesterol. They reduce the risk of heart attack and stroke in the patients. I have prescribed them. I respect them. I believe they can be life-saving for many people. But there is one conversation that never happens clearly enough. Statins lower cholesterol numbers. They are very good at that. Lowering cholesterol numbers is not the same thing as physically removing plaque that already exists. Those are two outcomes. Aggressive statin therapy can slow plaque growth. It can stabilize plaques. In some studies, it can produce small regression. But the amount of shrinkage is often tiny. Sometimes it is so small that you need specialized imaging to detect it. So when a patient asks, "Doctor, will this clean out my arteries?" the honest answer is not simple. A statin may reduce risk. It may slow progression. It may make plaque more stable. It is not the same as washing the arteries clean. Many patients are never told that distinction clearly. They leave with a prescription thinking the problem is being reversed, when in cases it is mainly being managed. Management is valuable. Slowing plaque growth is valuable. Lowering risk is valuable. Slowing a problem is not the same as reversing it. That distinction matters, because once you understand that plaque is not just cholesterol, you start asking questions. You begin to ask, what is holding the plaque together? That brings us back to fibrin. Fibrin is part of the structure. It is like the cement inside a wall. Statins may reduce the supply of cholesterol entering the system, but they do not directly dissolve the fibrin framework that helps hold established plaque together. Imagine a brick wall. If cholesterol is the bricks, fibrin is part of the mortar. A statin may reduce bricks from arriving, but the old wall can still remain standing. That is one reason cardiovascular disease continues to be such a problem even though cholesterol-lowering therapy has been used for decades. We became very good at focusing on one part of the equation. Plaque biology is bigger than one number on a lab report. So if oxidation begins the damage and inflammation keeps the fire burning and fibrin helps preserve the plaque structure, then the real question becomes this: can we target those pathways directly? That question led me to two compounds that changed the way I look at arterial disease: pomegranate and nattokinase. Let's start with pomegranate. There was a study involving patients with carotid artery narrowing. These were not healthy young people, these were real patients with measurable plaque-related disease in the arteries of the neck. One group consumed a daily amount of pomegranate juice, about 50 milliliters per day, roughly 3 tablespoons. Not a large glass, not a protocol, just a small consistent daily amount. Over the course of 1 year, the group taking pomegranate showed a reduction in carotid artery wall thickness. The control group, which did not take pomegranate, worsened over that period. That difference is what caught my attention. Because the result was not slower progression, it was measurable improvement. So why would pomegranate have this effect? The research points toward mechanisms. First, pomegranate is rich in polyphenols and antioxidant compounds. These compounds help reduce oxidation of LDL cholesterol. Remember, oxidized LDL is one of the main triggers that begins and accelerates arterial damage. If you reduce LDL oxidation, you reduce one of the signals that keeps plaque formation active. Second, pomegranate appears to support HDL function. HDL is often called cholesterol, but that nickname is too simple. HDL's real value is not just the number on a blood test. Its job is to help remove cholesterol from tissues and plaques and carry it back toward the liver for processing. So the quality and function of HDL matter. Pomegranate may help HDL do that job effectively. Third, pomegranate has inflammatory effects, and inflammation is not a side issue in plaque disease, it is central. A plaque that is inflamed is active, more dangerous, and more likely to progress. So pomegranate is not working through one pathway. It may reduce oxidative damage, it may improve cholesterol removal, and it may calm inflammatory activity inside the vascular system. That is why I found it so interesting. Quality matters. Not all pomegranate juice is the same. A sugary commercial drink with a pomegranate flavor is not what we are talking about. The research used pomegranate juice, pure, unsweetened, concentrated enough to deliver the active compounds. If someone uses capsules, the extract should clearly list its active polyphenol content. Consistency matters more than intensity. The study results were not from taking it for 1 week, they came from taking it over months. Now let's talk about the compound, nattokinase. When I first came across nattokinase, I was skeptical. That is the truth. Nattokinase is an enzyme derived from natto, a Japanese fermented soybean food. Natto has been eaten in Japan for centuries. Japan has historically had relatively low rates of certain cardiovascular problems compared with many Western countries. That alone does not prove anything. Dietary patterns are complex. People are different in ways. Something about natto caught the attention of researchers. It was because of an enzyme called nattokinase. What is interesting about nattokinase is how it works with fibrin. Nattokinase breaks down fibrin. This means it helps get rid of fibrin networks. Fibrin is important in forming plaque and blood clots. This is where things get important. If plaque is partly held together by fibrin, then something that affects fibrin breakdown could be useful. This does not mean nattokinase is a solution. It does not mean everyone should take it without thinking. It does mean we should pay attention to how it works. Some studies have shown that people who took nattokinase for months had less plaque. The changes were big enough to make me want to look closer, because this was not about making a lab test look better. It was about changing the amount of plaque in arteries. That is a big difference. One treatment might make your blood test look better. Another treatment might actually change the plaque in your arteries. These are not the thing. However, nattokinase can be dangerous if you are not careful. This is something you cannot ignore. Nattokinase can affect how your blood clots. It can make your blood thinner. If you are taking medications like warfarin, aspirin, or other blood thinners, you should not just start taking nattokinase on your own. This could increase your risk of bleeding. If you have a bleeding disorder, or if you have had a stroke, or if you have had surgery recently, you need to talk to your doctor before taking nattokinase. This is not about trying to scare you, it is just about being safe. Just because something is natural does not mean it is harmless. Things that are biologically active can have effects on your body. That is why they might be helpful. It is also why you have to be careful. Now let's talk about pomegranate and nattokinase. These two things are interesting because they do not seem to work in the way. They work on pathways. Pomegranate helps reduce stress on your body. It helps reduce the kind of cholesterol. It might even help your cholesterol work better. It can help calm down inflammation. In terms, pomegranate helps reduce the signals that make new plaque form. Nattokinase works on fibrin. It might help break down the framework that plaque is built on. In terms, it might help get rid of existing plaque. So one helps stop plaque from forming, the other helps get rid of plaque that is already there. That is why using them together is so interesting from a point of view. One stops plaque from building up, the other helps tear down the plaque. Now I want to tell you what I did. After I found out I had plaque in my neck arteries, I made two decisions. First, I was not going to panic. Panic does not help anyone. Second, I was not going to wait and see what happened without trying every reasonable option that is backed by evidence. I looked at the research. I looked at how things work. I checked my medical history. I was not taking any blood thinners. I did not have any bleeding problems. I had not had any surgery. I talked to a doctor I trust. Then I started taking pomegranate extract every day. I also took nattokinase at a dose that is used to treat people. I kept it simple because complicated plans do not work. I took it every morning and evening. I did not make any changes to my lifestyle. I just did it consistently. After 3 months, I got another ultrasound. The numbers had changed. The plaque in my neck arteries had gotten smaller. For me, it was 20 to 25% smaller. Now I want to be responsible with this. My result is not a study. It is one person. One doctor trying something on himself after looking at the research. It was real. It was something I could see on the images. It was enough to make me think differently. Because after working in heart surgery for 30 years, I have seen what happens when arteries get blocked. I have seen what plaque can do when it ruptures. I have seen families waiting outside operating rooms hoping for news. So when I saw my own numbers getting better, it was not just interesting, it was personal. It made me ask a question. How many patients have been told to lower their cholesterol without being told that plaque is also about stress, inflammation, and fibrin? How many people have been given a prescription told to come later without ever having a real conversation about whether plaque can actually be reduced? The answer, in my opinion, is too many. Now, why does this conversation not happen often? I do not think it is because doctors are hiding something. I do not think it is a conspiracy. The truth is more ordinary, more frustrating. Medical guidelines are based on expensive studies. These studies are often paid for by companies that can sell a product. You cannot patent pomegranate juice. You cannot patent a fermented soybean enzyme. So the research funding is smaller. The studies are smaller. It is easier for mainstream medicine to ignore them. Meanwhile, a cholesterol-lowering drug that is studied in tens of thousands of people becomes part of every guideline. That does not mean the drug is bad. It means the system rewards types of evidence more than others. There is also the reality of time. Most doctors are very busy. They have 10 or 15 minutes with each patient. They have a waiting room of people. They have lab results to look at. They have insurance rules to follow. They have medication lists to check. They have effects to worry about. They have follow-up plans to make. In that environment, a detailed conversation about plaque, fibrin, and nattokinase is unlikely to happen. Not because the patient does not deserve it, because the system is not built for that kind of conversation. Still, patients deserve to know more, especially people over 60, especially people with plaque in their neck arteries, especially people who are worried about stroke or heart disease. So let's talk practically. If someone is considering pomegranate, the basic amount that was studied was 50 milliliters of pure pomegranate juice every day. That is 3 tablespoons. It should be unsweetened. It should not be a sugary juice blend. If using capsules, look for an extract that clearly identifies the active compounds. The exact timing does not seem to be the important thing. What matters is consistency. Taking it every day for months is what is important. For nattokinase, the doses used in studies are often measured in units. Many capsules contain 2,000 units. Some protocols use daily doses. The correct dose depends on the person, their risk profile, their medication list, and their medical history. Again, if someone is taking blood thinners or antiplatelet drugs, this must be discussed with a doctor. Do not guess. Do not take blood-thinning compounds without thinking. Do not assume that just because something is sold as a supplement, it cannot cause harm. The smartest approach starts with measurement. Get a baseline. If you are concerned about plaque, ask your doctor about a carotid ultrasound and carotid intima media thickness. It is non-invasive. It does not involve radiation. It gives you something concrete to compare later. Without measurement, you are guessing. With measurement, you are tracking. That difference matters. You can repeat the imaging after 6 months or 12 months. See whether your arteries are actually changing, not whether you feel better, not whether a supplement label sounds impressive. Actual imaging, actual numbers, your own data. That is the way to approach this responsibly. You should also look beyond cholesterol. Ask about markers. Ask about insulin resistance. Ask about blood pressure. Ask about smoking history. Ask about stress. Ask about ApoB LDL particle burden and other markers your doctor may consider important, because cardiovascular risk is not one number. It is a pattern, and the better you understand the pattern, the better your decisions become. Now, I want to make one thing very clear. This is not an argument against statins. It is not an argument against doctors. It is not an argument against medicine. I am a product of medicine. I have spent my life working in hospitals. I have seen medications save lives. I have seen surgery save lives. I have also seen how incomplete conversations can lead to incomplete strategies. A statin may be appropriate. Blood pressure medication may be appropriate. Aspirin may be appropriate for patients. Lifestyle changes may be essential. If the conversation stops at LDL cholesterol alone, then we may be missing part of the disease process. Plaque is structural. Plaque is inflammatory. Plaque is oxidative. Plaque is biological. So our thinking has to be wider. That is the message. Not that one juice or one enzyme is a miracle. There are no solutions in heart health. There are things that make sense. There is a pattern. There is a way to measure things. There is a way to lower your risk. There is time. There is the amazing way your body can get better when you do the right things every day. If you are over 60, you should care about this. If you have cholesterol, you should care about this. If your doctor has talked about plaque or narrowing in your arteries, you should care about this. You should not just copy what someone else is doing. You should ask your doctor questions. Ask if your plan is about lowering your cholesterol. Ask if it helps with inflammation. Ask if it helps with damage to your cells. Ask if there is a way to check on the plaque in your arteries. Ask what your doctor wants to achieve with your treatment. Is it to lower your risk or to make the plaque go away? Those are goals. They need different conversations. Let me tell you the important things. First, lowering your cholesterol and getting rid of plaque are not the thing. They are related, but not exactly the same. Second, plaque is not about cholesterol. It is about lots of things like cells, inflammation, and other stuff. Third, pomegranate might help with cholesterol and inflammation. It might even help with the health of your arteries over time. Fourth, nattokinase is an enzyme that might help break down plaque. Fifth, nattokinase can interact with some medicines, so you have to be careful. Sixth, the best way to start is by measuring your health and talking to your doctor, not by guessing or being afraid, not by reading stuff on the internet. You need data and guidance. You need to be consistent and follow up. Months ago, I looked at my own arteries and saw something that worried me. It was not an emergency. It was a warning. Sometimes a warning is a thing. It gives you time to do something before things get bad. I decided to act. I decided to measure my health. I decided to think about it in a way. What I learned changed how I think about heart health. Your heart is not a machine. It is a living thing. It responds to what you do. It responds to what you eat. It responds to the way you live. That does not mean you can fix everything. It does not mean everyone will get the result. It means you can still make a difference. You can still change the way things are going. So start by talking to your doctor. Start by getting a scan. Start by looking at your numbers. Ask questions. Do not settle for an answer if you need a better one. Your heart has been working for you your life. It deserves your attention. You should take care of your heart before something goes wrong. This is information. It is not advice from a doctor. Your health history is important. The medicines you take are important. Your risk of bleeding is important. The pictures of your heart are important. What your doctor says is important. Now you know that you can have a conversation about this. Sometimes that is where change starts. I am Dr. John. Thank you for listening. Take care of your heart. It is always taking care of you.
That question led me to two compounds that changed the way I look at arterial disease. They're started with pomegranate. They're the second is involving patients with carotid artery narrowing.
I was not going to simply wait and watch. I reviewed the research. I looked at the mechanisms. I checked my own medical history. I was not on blood thinners.